how do you deal with complications?
Complications as they relate to PAD revascularization procedures are 1, rare, and 2, even when they do occur, they're mild in general. They're rare for a few reasons. 1, we have a selection phenomenon occurring. If you're a referring physician and you have a patient with wound and or leg pain, these are the 2 indications to refer to us. You don't have to do ABI, arterial ultrasound, nothing, none of that. We'll do all of that. Wound and or leg pain. Those are good indications for referral for PAD evaluation. So we hope you'll refer to us. However, if the patient that's in your office you're thinking about referring to us is a high-risk patient with comorbidities, for example, morbid obesity, say 450 pounds, or unstable cardiopulmonary conditions like unstable angina, COPD, unstable arrhythmia, that patient's high risk. As much as we'd love to evaluate and treat that patient should not be treated in the OBL. The patient should be in the hospital setting because he's high risk. Yes, the costs are higher to society and to the patient, but in that particular instance, the costs are worth it. We're triaging care to the appropriate, safe location. Now, overwhelmingly, PAD patients have PAD, but they don't have those comorbidities. They should absolutely be triaged to the appropriate setting, which is the OBL. Overall faster service, more customer service-like experience, arguably better outcomes, and certainly lower costs, which is very important. Lower costs to society and to the patient. So that's triaging care to the appropriate location. Some people have mentioned that this is a form of cherry picking, that we're only picking the easy cases and sending the hard cases to the hospital. This isn't true. It's a function of risk for the patient, not difficulty of the case. We do plenty of difficult cases in our OBLs where the patients are occluded both legs all the way down, but they're not high-risk patients. They don't have these comorbidities. Those cases are difficult, but we tackle them head on and we overwhelmingly deliver excellent revascularization outcomes. So it's not about easy or hard cases. It's about patients' risk profile. If they're high risk, whether they have severe, mild PAD or something in between, they should be done in the hospital because the complications tend to be unrelated to how severe the disease is. So we should sort of separate those, not conflate them. So this is not cherry picking. This is triaging care to the appropriate location for the patient, keeping value in mind and costs and experience. The experience and the value and the cost savings and the outcome, all of the factors equal, will be best in the OBL, hopefully in one of our OBLs. However, if the patient has the comorbidities, they should go to the hospital. So the selection phenomenon on the front end occurs that we don't often get a lot of those high comorbidity, high risk patients because the referring physicians appropriately decide to send them to the hospital. Great, we're on board with that. Occasionally, we will get a patient still sent to us. We'll do the evaluation, 7-point evaluation we do on every patient for their first visit. H&P, walking impairment questionnaire, photographs of the legs, ankle, feet, pedal pulses, handheld Doppler, ABI, duplex arterial ultrasound, every patient. So we'll do that evaluation. We will form a conclusion, say the patient has a right lateral malleolus ulcer, complete occlusion of the right SFA, complete occlusion of the right PT. That patient definitely needs a revascularization procedure ASAP. However, we identify that patient has comorbidities like we talked about earlier, morbid obesity, unstable angina, etc. We will send our consult note, our evaluation note back to the referring physician and say, thank you, Dr. Smith, for sending Mrs. Jones. However, and she meets all the criteria for procedure. She's got a right lateral malleolus ulcer. She's occluded all the way down. However, she has comorbidities. She's 450 pounds. She has unstable angina. She's high risk. She should be performed in the hospital. So as much as we love to treat the patient, we want to do the right thing. They should be performed in the hospital. So there's 2 selection points that occur. So we don't tend to get the high-risk patients. So all of the factors equal, we have even fewer complications than other PAD revascularization providers do. So that's why they're infrequent. The other reason they're infrequent is because it's a relatively safe, innocuous procedure. It's done through a small hole in the groin, minimally invasive, image guided. There's not a big incision. There's not general anesthesia. It's a small hole in the groin and it's conscious sedation. So it's a relatively benign, innocuous procedure. So there's just not a lot of complications. When they do occur, they tend to be mild. Like a groin hematoma is the most common, uncommon complication, which is just a collection of blood in the groin that usually resorbs. In addition, in all of the cities we're in and we're operating, we have relationships with local vascular surgeons who contribute to the care of our patients. And on the occasion that we have a rare complication, we reach out to them and they help take care of that patient, usually it consists of an overnight admit to the hospital and a discharge the next day. Again, this is extremely rare. Overwhelmingly, our patients are treated in our facility the same day, they go home the same day, and they're pretty much back to normal the next day. Complications are rare for the reasons I explained, they're mild for the reasons I explained, and even when they do occur, we have you covered.